I don't know where this recording is going to end up, but hopefully it saves to my computer so I can send this to Dr. Mung afterwards. So what we're going over is just this inflammation worksheet that can be found on Canvas. And we'll just kind of fill this in. If you guys want to participate, there's not very many people in the chat. You can unmute and just kind of contribute to whatever you'd like, or you can type, but there's only 2 of us in here. So I can also fill this in as we go too. We'll just kind of go with the flow and see how this goes. So let's start with this table here. So can you explain the pathology underneath the symptoms of acute inflammation? So we're talking about acute inflammation here, and there are 4 components of acute inflammation that are characteristic to every time acute inflammation happens in the body, regardless of where it is. You're going to see these characteristics. So we have redness, swelling, warmness, and pain. There are other words for these. Do you guys know the other word for redness that they might use?
Rubor, something like that.
Exactly. What's swelling?
Isn't it all Latin?
Yeah. So I can just kind of.
Okay, yeah. I don't remember it, but yeah.
No worries. Yeah. So swelling is tumor, warmness is calor, and then pain is dolor. You might see those terms thrown around just so you know what they mean. And we're talking about these 4 principles of acute inflammation. So why does redness happen when some area is acutely inflamed? What's going on to cause redness?
Vasodilation?
Yeah, exactly. So we're going to have vasodilation, but really what's happening is overall a change in blood flow to the area. And it's caused by, like you said, it's caused by vasoactive mediators that are going to cause those changes, like you said, Anne, which include vasodilation. So we're going to make those blood vessels a little bit bigger so that more blood flow is going to go to the area, and blood is red. So it's going to create this redness to the area. We have some other things that are going to happen too, like increased permeability, because the endothelial cells are actually going to retract a little bit, get farther apart. So we're going to have more components of blood leaking into the area. But I guess we'll just stick with this for now because we're just talking about redness. And that's really just the vasodilation and the increased vascular permeability. So we have more blood coming into this area that has all these immune cells that are going to help clean up the area or fight whatever is causing the inflammation. So maybe I'll move this down here because this is really why we're going to have more of this swelling. So increased permeability of vasculature. That's really why we're going to have swelling in the area. And when we're talking about the increased permeability of vasculature, can anyone tell me what's going to be leaking out of these blood vessels?
Proteins.
Yeah, exactly, Tanya. So we've got a lot of plasma proteins. We have leakage of cells like leukocytes. So we call that leukocyte migration. They're moving out of the blood vessels into the area of inflammation. So all of this stuff leaking out of the blood vessels is what's causing the swelling locally. Now, we have a name for this combination of plasma proteins and leukocytes that have left a blood vessel because of the increased permeability. Do you know what that's called?
Edema.
Edema is really close. So edema is kind of another word for swelling, but this one starts with an E as well. Do you know what, is it EX?
Yeah, when it's
Yeah, exactly. Exudate.
yeah.
So we're going to form exudate, which is very different from something else called transidate. And transidate is going to be formed from other components in the blood, kind of leaking out of the blood vessels, but it's going to be more of a watery mixture versus this being more of a creamy mixture with the leukocytes in there. When you think of exudate, you can kind of think of pus, is how it helps me remember it. And that's what's going to be involved when we're talking about inflammation. It's exudate. Transidate is not really something you see in inflammation. It's something you see when you have changes in your hydrostatic and oncotic pressures. So like congestive heart failure, where you have a really slow backup of blood coming into the heart because it can't pump it. Areas where you got to have this increased blood just kind of staying there has an increased hydrostatic pressure. So more stuff is leaking out of the blood because of that increased pressure. And if the body can't drain it fast enough using lymphatics, you have this buildup of transitant. So they're very different things when we're talking exudate and transitant. So it's definitely good to know that difference. All right, I think that's everything I wanted to say about that. Let's talk about warmness. And I don't want to just put you on the spot, but you are the only one in here. So do you want to tell me about the warmness of acute inflammation? What's causing the warmth in that?
The blood.
Yeah, exactly. So we can really just kind of copy this and put it there. It's really the change in the blood flow that's causing more blood to be in the area. Blood's moving slower through the area. It's just bringing warmth, because where we have blood, we're going to have warmth. So perfect. And this one's kind of a tricky one. Do you know what's causing the pain and inflammation?
I would say it's a combination of the swelling and the nerve endings in the area that cause the pain.
Yes. So swelling is going to kind of interact with these nociceptors or pain receptors in the body that are going to respond to that swelling and give us this painful stimuli. And there's also one other thing that can cause an increased sensitivity to any kind of pain stimulus. Do you know what that is?
I'm thinking.
So it's actually, these are things like prostaglandins, which are eicosanoids. And these are released during inflammation. And there's one in particular, which is PGE2, which is going to really be involved in creating hypersensitivity to skin. Any painful stimuli is just going to be felt greater with this PGE2 going around. I'm going to wrap this text. Perfect. All right, so those are the 4 components of acute inflammation. Now let's kind of move down here and get into the differences between acute inflammation and chronic inflammation. They're very big differences, and we have them outlined here. So when we're thinking about some of the causes of acute inflammation, what are some that you know of, Tanya? And I don't mean to put you on the spot. I can totally stop if you want and just kind of like talk about this, because I know you guys just learned the material.
It could be like from like a splinter.
Yes.
Worm.
Yeah. Definitely. So anytime you have some type of foreign substance in the body, we're going to be able to recognize that. So we can kind of divide these into external causes, which would be something like a foreign body entering or penetrating the skin. Or you might have pathogens, which are going to get into our bodies wherever they're getting into, and they're going to cause inflammation too, so that we can fight that.
Molecules that release necrotic cells.
Yes, exactly. So we'll call that an internal cause. So, oops, I keep doing that. Forgive me. Still getting used to this program. So like you said, necrotic tissue. We learned last week that necrosis is going to cause inflammation while apoptosis won't. The reason for that is because when we have necrotic injury or death to the cell, not injury, you're going to have kind of release of a lot of things out of that cell that shouldn't be out of that cell, like DNA, ATP, uric acid from the breakdown of DNA. All these kind of molecules are going to leak out of the cell, and tissue, especially local macrophages, are going to know this is not normal. We need to respond to this with some type of inflammation. And that's what causes inflammation. And I'll just kind of talk about a couple of receptors that are really important in this. They're called pattern recognition receptors, PRRs. You're going to learn about them in immune system. I'm not sure if you guys have talked about them yet, but I want to throw them out here because I feel like it's really important. So pathogens like bacteria, fungi, there's going to be certain patterns in their cell wall. Maybe it's peptidoglycan or some type of substance that our bodies have evolved to understand. This substance is bad and we don't want it because it's from some foreign pathogen. And receptors that are going to pick up on these patterns are known as PAMPs. And a PAMP is a pathogen associated molecular pattern. And these PAMP receptors or PAMPs are going to bind to pattern recognition receptors, which are on all cells in the body. And when they interact with that receptor, it's going to cause inflammation. So our body knows really when there's pathogens in the body, and PAMPs are kind of how we're going to be able to know those because there's patterns associated with these pathogens. And then there's another one that's really close to PAMPs that's known as DAMPs. So these are damage-associated molecular patterns. And again, those bind to PRRs, pattern recognition receptors, which are all over the body. And when the body sees, okay, we've got damage-associated patterns like DNA or uric acid kind of in this tissue, we're going to activate our innate immunity and cause inflammation. So I think that's good for the causes. What are the cells involved in acute inflammation versus chronic inflammation? Do you know the main cell difference?
Yeah. In acute, there's neutrophils. And in chronic inflammation, there's macrophages. That's the main ones that I remember.
That's perfect. And I'll just kind of put in this graphic here. Just as a kind of a cool little graphic to show us the reason for that. So this is kind of a timeline of how long inflammation has been going on. And this is measuring the activity of different mechanisms like swelling or just the different cell kind of migration. And in this case, we're talking about neutrophils and macrophages. And we can see that neutrophils are really short-lived, kind of going away after about 2 days. You can still have some coming into the area. But what this graphic is kind of showing is that after a while, if this inflammation is still ongoing, the main kind of cell that's going to be left is going to be these macrophages. So yeah, that's perfect. I'll just put that in there for reference.
Okay.
Yeah, so that's perfect right there. I don't think I want to say anything else. We can talk about mediators now. So do you know what are kind of the 3 classes of mediators that are involved in inflammation?
No, prostaglandin is one.
Prostaglandins, yes. So we'll kind of put those under the classification of icosanoids. And then do you remember the other ones?
Leukotrienes?
Yes. So we'll say prostaglandins and then leukotrienes. So those are both icosanoids. And there's also other things like IL-1 or IL-6. Do you know what those are classified as?
Interleukin.
Starts with a C. It took me a long time to know the difference, so that's why I'm just emphasizing it.
They're not chemo or cyto.
That's it, cytokines.
Yeah, cytokines or chemokines.
Yeah, exactly. So chemokines are kind of like a type of cytokines, that are going to help kind of attract different cells to the area of inflammation. So that's definitely an inflammatory mediator because inflammation is the presence of these white blood cells in the area. So chemokines bringing white blood cells in the area, they're definitely involved in inflammation. And kind of the main cytokines that you always want to think about when you're thinking of acute inflammation, there's 3. Do you know them?
Is it IL-1, IL-6, and IFN, I think?
Super close, super close. IFN is more chronic inflammation, and we'll talk about that. This one is ENF.
ENF, okay.
Yeah.
TNF.
You got it. Like if you can remember those three involved in acute inflammation, you'll be golden because you're going to be hearing questions about that, especially in immunology throughout the year. Okay, what are our pro-inflammatory cytokines? It's going to be really emphasized on the NPLEX. So now is a great time to just make a couple flashcards and just remember these three cytokines for now. We can talk about what their main effects are. So IL-1, this is going to be really involved in fevers because IL-1 is going to act on thermoregulatory centers, I believe in the hypothalamus, somewhere in the brain, and it's going to increase the body temperature, which is really good when we're fighting off pathogens like viral infections because it's going to help all of our white blood cells act a little more efficiently with that increased body temp. So IL-1 is really important for fevers. It's also going to create acute phase proteins in the liver. So those are really involved in things like complement. And there's also other acute phase proteins you're going to talk about in immunology. But know that IL-1 is going to help kind of cause transcription of those things. And I think that's all I want to say about that. IL-6, really systemic inflammatory effects, similar to IL-1. TNF, this one has a couple of specific functions. It's going to stimulate endothelial adhesion, secretion of other cytokines, and we already said adhesion. So again, just kind of helping with this inflammation. I'm not sure how important it is that you need to know what are the differences between IL-1 and IL-6 just yet. I think later on that becomes more important, but for now, just recognizing these are the cytokines that you're going to see in acute inflammation specifically. That'll be a great place to start. Now I want to, yeah. Do you have any questions about any of these, Tanya?
Not as yet, but I do want to add that I have to go take my test. And so I'm going to leave like in 6 minutes.
Yeah, perfect. Leave whenever you need to. I'm just going to keep on going just so we have this full hour of the recording. But thanks for sticking in and contributing as much as you have been.
Thank you.
So let's talk about a couple prostaglandins really quick. I want to make sure we can finish this in an hour, so I won't go too in depth, but some prostaglandins. Well, first of all, what are prostaglandins? Do you know what enzyme is going to be responsible for making prostaglandins? Starts with a C. So this one is I see you. Sorry. So this one's cyclooxygenase. So they kind of abbreviate them COX-1 and COX-2. I think it's, were you trying to say something? I think it's breaking up on my end.
Yes, almost.
Sorry.
Along the line of that. Is that the, no, sorry. I don't want to mix anything up.
No worries. There's a lot of different enzymes at this point. So I can kind of explain, and then if you have questions about it, definitely let me know. But cyclooxygenases, these are just enzymes involved in pretty much most cells in the body, but especially inflammatory cells. They're going to use cyclooxygenase to make these eicosanoid products, specifically prostaglandins and thromboxanes. So these eicosanoids are made by cyclooxygenase, and we have COX-1 and we have COX-2. Important to know the difference between those. I would just say COX-1, this is the one expressed in most tissues.
I could ask a quick question. Is that the same enzyme where that's what gets inhibited to relieve pain?
Yes.
Yes, okay.
Exactly. So we're going to inhibit for pain relief, for anti-inflammatory actions. So things like aspirin, which is an NSAID, like acetaminophen, celecoxib, lots of drugs act on these cyclooxygenase enzymes to inhibit them, which is going to stop the production of prostaglandins and thromboxanes. We want to inhibit thromboxanes when we want to have a blood thinning effect like aspirin. You can take a baby aspirin every day to kind of thin your blood out and decrease your risk of heart attacks and stuff like that. Or prostaglandins, if you inhibit those being synthesized, well, that's going to have a pain relief effect, right? Because we said prostaglandin E2 is involved in painful stimuli becoming more painful. So if we can stop that, we're going to have decreased pain. If we can stop, really just stopping this pathway is very anti-inflammatory. So really good catch there. And we'll just kind of differentiate between COX-1 and COX-2 because this is important later on, especially. COX-2 is expressed in really mostly cells involved in inflammation. Versus COX-1, so that's why it's, if you use aspirin or NSAIDs too much, you're going to suppress different homeostatic mechanisms in the body, because COX-1, we make these eicosanoids also to manage the mucosal lining of our stomach, right? So if we are inhibiting different prostaglandins involved in our defensive mechanisms in our stomach, you can have an increased incidence of ulcers because of this inhibition. So you have to be careful with these, but mostly they're anti-inflammatory. But when you inhibit COX-1, you're gonna have more side effects. So sometimes they'll try to selectively inhibit COX-2 to hopefully prevent those ulcers. All right, I'll skip leukotrienes. There's not really a whole lot to know about them, except that they're made from a different enzyme, lipooxygenase. So those are LOX. And I would just say no, the COXs and LOXs, they're involved in making eicosanoids, and no, these two are made from cyclooxygenase, and leukotrienes are made specifically from lipooxygenases. All right, and then we'll just say one more class of inflammatory mediators. This is going to be vasoactive amines. And the one that I would definitely think of when you're thinking of these, you want to think of histamine. That's going to be involved in increasing permeability to blood vessels. So very much a mediator of inflammation there. All right, so quickly, we can just say duration. In acute inflammation, would you think it's going to be short or long? I know that's kind of a really simple question, but
It's short.
yeah, exactly. We don't want this to go on a long time. If it does, then you're going to transform into chronic inflammation, because that's going to be the result of acute inflammation the body couldn't get a hold of. It's very short, and we'll just say this is long, can last months to years, long time. Chronic inflammation is not fun, and it can last a long time. But the outcome for acute inflammation, this is a good mechanism in our body. It's healthy to have some acute inflammation. The outcome, would you say it's a good outcome? There's not a lot of injury, or would you say there's a lot of injury in this type?
I say it's a good outcome.
Definitely, good outcome. So very low damage going on. The body is able to kind of keep this under control. It's pretty self-limiting. It's a good outcome. Versus chronic inflammation, which we'll get into, and I know you got to go, but this will be on the recording too. The outcome of chronic inflammation is going to be a little more devastating in some cases. This can be actual tissue injury, death.
Fibrosis?
Yes, that's the main, and I'm going to bold that. Fibrosis is so important, because when you have this tissue injury going on, we have to keep on laying down fibrous tissue just to repair it. And we'll talk about the summary of cell repairs and where that fibrosis comes into play. It's definitely not good, especially in heart tissue where you lose functionality of the tissue, because if it can't replicate, you're just going to lay down fibrous tissue, and that's not functional, just protective. All right, we can get into chronic inflammation. So for this, causes of, and let me turn off my notifications really quick. Okay, so chronic inflammation. The causes of this are really similar to acute inflammation. It could be from pathogens, it can be from foreign bodies, but the difference here is that it's going to be pathogens that are persistent. So we can kind of separate this again into external and internal causes. So chronic foreign body exposure, maybe through the air you're breathing or the food you're eating, potentially through persistent pathogens, which could be a problem in immunocompromised states. And then internal causes of chronic inflammation can be things like hypersensitivity and autoimmune diseases. All right, and we already talked about the cells involved in chronic inflammation. There's a couple others that are involved in chronic inflammation that we want to note as well, and those are going to be lymphocytes as well as fibroblasts. These are the ones that lay down scar tissue. Lymphocytes are involved in really a lot of chronic inflammatory reactions. They're the ones that are really involved in secreting cytokines, involved in chronic inflammation, which we'll get into in the next box. And they're also involved in granulomatous inflammation. That's dependent on lymphocytes. So these are kind of the three cell types, but definitely know the macrophages as the number one. And there's the reason they're dominant is because they have a longer lifespan than neutrophils. So they're going to stay in the area a lot longer. And they're going to be the ones really producing most of the injury involved in chronic inflammation. And they're going to do that through reactive oxidative species, so ROSs, and other things like hydrolytic enzymes, just being released into the area, and they're just not controlled as well because we have this chronic inflammation picture. We have chronic injury going on. Maybe our antioxidants aren't working as well enough, but we're just having this chronic buildup of damage because of these things released from macrophages. All right, so the main mediators of chronic inflammation, the main ones are going to be cytokines. And the main cytokines that you want to be thinking about are going to be IFN gamma, which is going to be involved in activating macrophages, which you guys will learn in immunology is going to increase their ability to kill microbes and other things we're trying to destroy in the body. So IFN gamma is really important. We know macrophages are really involved in chronic inflammation. How do we activate them? It's through IFN gamma. And there's other ones like IL-12 and IL-17 that you'll want to be aware of, but I would say IFN gamma is the most important one. And I think in immunology, you're going to cover this a lot more in depth. All right, so that's it for that table. Now we're going to get into the summary of cell repair, of tissue repair. So we've got a lot of steps here. We'll kind of write them all out. And I see we kind of have step 0, which I'm kind of interpreting as maybe what has to happen before the 5 steps you guys go over in class. And what you guys went over in class are inflammation is the first step. We have angiogenesis. We have migration and proliferation of fibroblasts. scar formation, and connective tissue remodeling. So we'll kind of go through this and then we can add maybe a step here, which is really just blood clotting, which may need to happen before all this stuff happens too. That way you're not continuously bleeding into your wound. So we just need to put blood clot formation or hemostasis. And we can just quickly say, so we need to form blood clot at the site. That's going to be done through platelets. Fibrin is going to form this mesh, which is going to be laid down on the area. You want to review all those concepts of blood clot formation from physiology last year, because that's part of this tissue repair process. So now we're going into inflammation. So now we've stopped the bleeding. The wound is now going to get inflamed because we need to clean up some of the debris in that area, maybe some dead cells that were injured, or maybe some microbes to stop them from infecting the wound. We need inflammation to come in. We talked about all of that up here. So we'll just kind of say as described above. This is to clean up debris, dead cells, etc. We'll add microbes too. Now, angiogenesis is the formation of new blood vessels. And this is going to be done through different growth factors like EGF, endothelial growth factor. And we're forming just new microvasculature to the area to bring in whatever we need to help with the wound healing process. So, and one term you want to be aware of here is something called granulation tissue. And granulation tissue is essentially just newly formed blood vessels kind of lying on top of a lot of new fibrous tissue. So it's a combination of new connective tissue and microscopic blood vessels that form on the top of wounds during the healing process. And depending on the type of wound, you're going to be needing to lay down more granulation tissue or less granulation tissue. And we're going to go into that on the next one. I'm not sure how in depth you guys are expected to know this, so you may want to skip this part, but there was mention of these terms in the PowerPoint, so I just wanted to make sure we talked about them. So when we have migration, actually, I'm getting ahead of myself. Forget what I said, we'll talk about that in the next step. This is something a little bit different. So now we're talking about migration and proliferation of fibroblasts. You guys remember from histology, fibroblasts are always kind of hanging around in connective tissue, but they're quiescent at first. We don't need to continuously lay down collagen. So they go to sleep for a little bit, but they become activated in this wound healing process. So we're going to activate these fibroblasts to produce collagen. And that's going to be replacing whatever dead cells or ruined tissue that had happened from that wound. Now we're going to lay down a lot of collagen. And it doesn't always look as pretty as it did before. So that's why scar tissue has a different look than other normally arranged tissue types. So now let's talk about the actual scar formation process. We all know from different wounds, different scars are going to, or different wounds are going to form bigger scars. So the reason for that is just based off how that wound is going to be able to close. And there's two different processes to explain how we're going to get a wound to close. And this is going to be first intention and second intention. And first intention you can think of as a minor cut. This is something that's not very deep. So the body is actually able to control it, or the area is able to control it just kind of by doing this thing called re-epithelialization. So we need to close the wound so we don't have a bunch of bacteria kind of entering the wound and causing secondary infections. So we need to kind of reform that innate defense, which is our epithelial layer. So we're going to have mitosis of our stem cells, especially in that basal layer of the epidermis. They're going to proliferate, and they're going to kind of move laterally underneath the cut to close off that area as best as they can, if it's a minor cut, right? So if this is a huge cut, you may not be able to close the wound alone with just reepithelialization. You might need something else, which is that granulation tissue. There's going to be a lot more of that. When we're talking about first intention, though, there's not really going to be a whole lot of granulation tissue. So we don't have a whole lot of angiogenesis, like, right, you scrape your arm. We don't need to create too many blood vessels, but if you burn off an entire area of your arm, then you definitely need some new blood vessels coming in. But we're thinking this is a minor wound. So we don't need very much granulation tissue. Also, little scarring. Small wounds don't generally form a ton of scarring, and minimal contraction. So sometimes if you have a lot of fibroblasts laying down collagen, they can also contract with that collagen and kind of cross-link the collagen a little bit as they contract. And it's going to kind of bring the wound together to close it off even more. But if you have a minor cut, why would you need to do that? So let's look at the difference here when we talk about second intention. This is a large wound or a burn. And what happens here is reepithelialization is not enough. So first intention cannot happen in this case because of the wound. So what has to happen instead of reepithelialization is connective tissue proliferation. The dermis, which is underneath the epidermis, and that's going to just kind of move from below, move upwards to kind of seal the wound. Instead of moving laterally from the skin intact adjacently, we're now coming from below and replacing that tissue with connective tissue from below. And because of this, we're going to be having a lot of connective tissue proliferation, a lot of angiogenesis. We need a lot of material, so we're going to build some more blood vessels. We're going to lay down a lot more connective tissue. So what is that a great combination of? That's granulation tissue. So lots of granulation tissue. You're going to have scarring, definitely, if it's a big wound. And also you're going to have contraction, which are, again, those myofibroblasts that are able to contract to help close the wound. So maybe you want to know the difference between these two, but definitely just know this is part of this scar formation. And then lastly, we have connective tissue remodeling. And we already kind of talked about this. The collagen is more disorganized, and there's scar tissue at the wound. All right, I think we can finish this in 6 minutes. So our last table here is just kind of differentiating these two very different terms that sound the same. So we just talked about granulation tissue. What's the cause of it? It's wound repair. Specifically second intention wound repair, where you have a large, deep wound that cannot close by first intention alone. So we're going to lay down, again, new connective tissue from fibroblasts and new microscopic blood vessels from angiogenesis. It's this like red, grainy looking tissue. That's what we're talking about when we talk about granulation tissue. Now, the main component, I already put that here, so we'll just kind of add that here. This is new connective tissue and microscopic blood vessels. And just so you know, this can fill a wound of almost any size according to your textbook. So that's interesting. I don't know what they mean by almost any size, but I guess there are limitations to everything. Now, granulomatous inflammation. This is very different than granulation tissue. A granuloma is actually a subtype of chronic inflammation, and it's a response of the immune system to a pathogen that is very persistent or maybe the body is just weakened in some way and it's not able to deal with that pathogen effectively. So what happens instead is the body doesn't surrender, but it does something kind of similar to where it just kind of walls off the area. We're going to contain this infection and we're going to form this granuloma in the area, which can stay there for quite a while. So in summary, the immune system is attempting to contain an offending agent that it cannot eradicate. So maybe it's some type of infection. One infection that's really prone to causing granulomatous inflammation is tuberculosis. You've got other like leprosy, syphilis, and others that are prone to causing these granulomas. And the granulomas can be described in different terminology, like Crohn's disease forms non-caseating granulomas. Just so you know, you're going to be hearing the term throughout the year, and you want to know what is a granuloma, and that's what this is all about. It's just something the body can't get rid of, so we're going to wall it off. And the main components are going to be immune cells, and they're forming nodules. So it's a collection of immune cells walled off. And how we're going to be walling these off is macrophages are going to form these epithelioid cells, which are basically just large macrophages that appear to look like epithelial cells. So they're called epithelioid cells, but they're really enlarged macrophages, and they're really characteristic to these granulomas. And you also find lymphocytes in there as well. We talked about these being dependent on lymphocytes above. All right, I think that's everything that I wanted to say. Yeah, so I'll go ahead and stop the recording.